case. So I think we begin with our first presentation. Our first presentation comes up from Dr. Rohit Parkash. He's a very senior consultant and an expert in handling such cases. Over to you, Dr. Rohit.
Thank you, Dr. Priya, for calling me over. It's a privilege to be here. So I would be taking up what Dr. Priya asked me to talk about anterior capsular flutter. So, basically, we all come across this situation wherein at times we have a rhexis tear and at times we end up with an Argentinian flag sign. Well, this is basically a good surgical dilemma because at times we can complete phacoemulsification and whereas there are other times when we cannot and we end up in a catastrophe. So this is what the surgical dilemma is. But there is a very good silver lining, and that silver lining is that radial tears do not easily and fast become wraparound tears. So mark my words, they do not easily become a wraparound tear. Why? Because of the thickened mid-periphery of anterior capsule, and there is a barrier created by zonular anterior capsular attachment. So these two things are the positive things in it, but then that doesn't mean that we should not take care of it. Well, the first thing which you should bear in mind is no panic mode. Because what I have seen is whenever there is an anterior capsular tear, the first thing which comes in people's mind is let's convert. No, there's no need. Why there is no need? Because we have to take care of two things. First, we have to evaluate the extent of the tear. Do we have the means to do it? Yes, we have the flap motility sign. But that should not be the end of the story. This is only the first half of the story. Because if we do not adopt safe phacoemulsification techniques, we will end up in catastrophe. So that is what we need to take care of. But before we really go into the details, I would just like you to refresh what really the flap motility sign is. Well, the evaluation of the can be made out by the flap motility sign if the anterior capsular tears are everted and fluttering. It means it's a pre-equatorial one. And if by any means it stops fluttering and it becomes inverted and then it's a wraparound tear because it is a non-fluttering and inverted flap. What next? Well, the first thing is let's evaluate. And how do we evaluate? The evaluation is by just injecting visco, and you will see when it was injected, the flap became everted. So that is the first sign that it is pre-equatorial. Let's see it again. And when we see it again, we again inject visco and the flap is again everted. So this is diagnostic of the thing that it is a pre-equatorial flap. Let's reconfirm. And how do we reconfirm? We just put in on irrigation mode and you find, can you see the flap fluttering? This shows that it is pre-equatorial. Let's reconfirm it again in another case. Again you will find the fluttering flaps. So this shows that it is definitely a pre-equatorial flap. Next question is, how do we evaluate it because we are busy doing the surgery? Well, there are two ways. When you are doing the surgery, you can intermittently have a look. Or secondly, what you can do is you can ask your assistant and tell him to have a look at the flap. And you will find that if by this method, because in our OR we have people, assistants who really let us know whether it is fluttering or not. So to really evaluate whether it is a pre-equatorial one or not. Now what is the surgical plan? The first prerequisite is have a stable chamber settings. Take care of your stepson, which happens to be the side port incision. Let it be calibrated so that we have stable chamber settings. Next is fluidics. The fluid control in the palm, what do you mean by that? It means you should have active fluidics. Because with active fluidics, it is not a reactionary one as it is in a gravitational one. And at low fluidics, it really doesn't work. But I do not have by any means any financial interest whatsoever. Next step is slow motion phacoemulsification as has been shown by Bob Osher and our own Abhay Vasavda. So slow motion phacoemulsification idea was conceived very much in the 90s, but it has come up a long way because with the involvement of active fluidics. What happens with this? There is an equal or minimal pressure difference between anterior and posterior segment. So that is a very important part in the whole story. So moving on next, so we have the surgical planning with us. Next is, what are the techniques? I've already talked about low IOP phacoemulsification, slow motion emulsification, stable chamber settings, because it's not that, that you go and put it on low IOP. You have to create a fluidics wherein you can have stable chamber settings and which need to be titrated as and how you move from a higher setting to a lower setting. Site of incision. Well, does it have a relevance? Yes. It has relevance in relevance to the axis of rhexis tear. Then we should create additional rhexis extensions which has been traditionally, which we all are aware of. No pushing of nucleus while trenching. Avoidance of wide separational forces. Separational forces in the direction of tear and supracapsular emulsification. So let's see these points and I'll show you how we do it. High settings. What do the high settings do? With an anterior capsular tear, chamber instability, pressure flow, it creates a situation wherein it becomes a wraparound tear. And when we use low settings, the chamber settings are there, we are not putting stress to the end point of the flap, not making it go and predisposing itself to become a wraparound tear. Low settings are very important. You should use 20 or 24, 26, but not in one go. You have to gradually graduate it in normal cases so that you can do phacoemulsification in such situations. The aspiration flow rate is around 23. So this is what, and with this, all these things which I have already talked about. Flap motility sign was published way back, we are all aware of. So safe techniques I've talked, let's see this. Now in this you will find the first thing is site of incision. Now what is this site of incision? This site of incision is not in line with the rhexis tear. So that is the first thing. So this is a good factor. And if we see the fluidics, it is around 20 IOP and 23 is this thing. No pushing, no pushing while sculpting. And the next part is, it's a hard cataract, grade 4 cataract. Chopping is there. See the direction of separational forces. The direction of separational forces are in the line, in the axis of the rhexis tear. So that is another very important factor. So this part is now continuing. Again chopping it, separating it, flap fluttering, reconfirming that it is a pre-equatorial one. Slow motion, with this amount of fluidics, you are not pushing it behind. So I'm using the Savra's technique and I'm debulking it. Why I am trying to take out one nuclear fragment? Because I want to debulk it so that there is less pressure on the flap end so that it becomes less predisposed to a wraparound tear. So you will see now I am doing a slow motion phacoemulsification, but at the same time you will realize that all these flaps, 1, 2, 3, and I cannot see the fourth one, they flutter in between. So this is reassuring, because at times what happens is that these two flaps are fluttering and out here one of them stops fluttering or both of them stop fluttering. So that may be a sign which we may be missing. So I'm now moving around. Now let's see what is going to happen is that I'm going to show you what I do is, so this is a very hard cataract for that matter. See, because I'm doing it slightly anteriorly and the fluidics are low, I'm placing this chopper slightly anterior to the phaco tip. Now what will that do? It is acting as a shield and it is protecting the corneal endothelium from any insult whatsoever from the nuclear fragments which would chatter and go astray and hit it. Stable chamber settings is another important thing. And the next thing which I am doing is, you will see the flap is fluttering. I'm taking out the cortex remnant, whichever were there, and the process is again stable chamber settings, intraocular lens implanted, trying to make the rhexis slightly bigger, and while doing stromal hydration, the flap was still fluttering. So now the next thing is Do we always succeed? The answer is no. We should know what is the end point of safe phacoemulsification. And there are conditions when the surgeon is not aware of the intricacies of all the techniques and he's not sure, and in that condition, as it always happens, he converts. So let's see in this video, the surgeon, he's trying to enlarge the rhexis. In an effort to enlarge the rhexis, he ended up in a situation where there was an anterior capsular tear. The emulsification is carrying on, and while dividing, the flap stops fluttering. Now what does that mean? This means this is the end point of safe phacoemulsification. So the surgeon who was oblivious of the relevance of flap motility sign continued and ended up in a situation wherein there was a catastrophe and the nucleus dropped. It is not Dr. Amar Agarwal's operation theatre where it is not a catastrophe. He would have done everything, and it would have, for all of us humans, it is something which we should be aware of is a catastrophe for most of us. So in conclusion, do not panic. Evaluate the extent of the tear of the flap by flap motility sign, no endpoint of safe phacoemulsification. Site of IOL implantation is very important. Safe phacoemulsification techniques, which I have already talked about. A word of caution, I have already said, all 4 flaps should be fluttering. Pre-existing PCR should be ruled out. Pre-existing PCR may give a false positive pre-equatorial fluttering and everted flaps. Posterior capsule rupture. Do I have 3-4 minutes with me? Yeah. Just let me know whenever I have to, So PCR, if it is there, what next? Let me create a situation wherein, let me show you how, if we diagnose PCR, what are the early things which we can do. This is a right eye, the patient has a fibrotic cataract. The left eye is pseudophakic with optic capture. So there might have been a PCR. That was something which was a very big deterring factor for me. Flax was done because in fibrotic cataract you want to create an intact rhexis. So flax was done, a smaller rhexis was created. The emulsification was started. It's a hard cataract. After creating an initial trench, the chopping was done the way Dr. Abhay Vasavda has shown, multi-level separation. So it was done to achieve total separation. Then it is in 2x now to save time. Once the chopping was again done, suddenly there is a PCR. Now the idea is, what next? Should we just pull it out as traditionally it should be, or should we go ahead? Well, there's a change in surgical plan now. What I did was, I lowered the IOP to physiological setting. I decided not to rotate it, do slow motion phacoemulsification, use IOL as a scaffold, do supracapsular emulsification, do IOL capture, and I may or may not be able to use toric IOL as it was already planned in this patient. So now what is going to happen is, let me brighten it up. We started. The first thing which I did was, I just pulled it out with the low IOP, the nuclear fragments were just floating. They were not being pushed behind. The posterior capsule was not bored out. It was not bulging. The vitreous by any means anterior phase was not going to be ruptured because the fluidics were going to be on the lower side. There would not be any breaking up of the anterior hyaloid phase. Now again I am caught on the wrong footing. This is a subincisional one with posterior capsule right across. You will find at this stage that there is some dimpling in the cornea. This shows that I have used low fluidics and I am not pushing it. So what I am going to do is, I am going to use a small trick, go slow, don't push it behind, and the moment I cross it, I'll pull it up and then take it out. And then the next step would be, once I do it, I'll use IOL scaffold, which would be aptly shown as and how we go ahead in the course by Dr. Priya and Dr. Amar. Uh, and you will see now what is the advantage. It acts as a PC, the IOL. You can work at a deeper level. You can take care of the endothelium and the posterior capsule and the nucleus from going behind. And I'm doing it in a slow way. When I'm doing it in a slow way, it's just sticking to it with less fluttering, stable chamber settings, and the case was easily completed. So this is another situation where I would like to show is that, this patient had multiple anti-VEGF injections. So the visual acuity improved from 636 to 618 and dropped to finger counting in 2 months' time. So I think in this you will find so in this also the low fluidics were used, and by using flow fluidics we created a situation wherein we were able to save the nucleus from going behind and the IOL could be easily completed. So friends, whenever we have PCR, the most important thing which we need to bear in mind is that if we take care of fluidics, there are cases around when you suddenly say that I started with phaco and suddenly the nucleus went behind and there is no fault of mine. Well, the idea is at times there is a PCR with the high fluidics, with high gushing of fluid, the nucleus falls behind. Low fluidics, aptly used, can save your day. Thank you very much for your kind attention.
Thank you so much, Dr. Rohit. It was such an informative talk, and we learned quite a bit about it, like, how to go ahead. Thank you so much for